So my name is Pierre-André Jérôme, and I'm the Global International Product Manager for Vastarel, working for Servier, of course. And I would like first to warmly welcome you for this live session. So as a short preamble, I would like to remind that it's estimated that angina affects more than 100 million patients globally. And among those patients, the point to note is that among patients already receiving anti-angina treatment, 40% of them continue to remain symptomatic. And they all reported that it completely impacted their quality of life. So I would like to ask one question. How can we better optimize angina therapy in view of the recent guideline recommendation to free our patients from debilitating angina symptoms? So to answer this question, I think you have noticed, because we can see that Dr. Quek will animate this live session, and it's a great pleasure to me to welcome him to animate this session. So just a bit of context. Dr. David Quek is a senior consultant cardiologist at Pantai Hospital in Kuala Lumpur, Malaysia. He has served as principal or national investigator for various landmark trials and for some of the Vastarel trial. He has under his name almost 50 publications in peer-reviewed journal and more to come. So now for some little general information about this webinar. This webinar will be divided into two parts, the lecture by Dr. Quek, and then a Q&A session in which Dr. Quek will answer all of your questions. I would like to attract your attention that this webinar will be recorded. This is a team event, so kindly ensure that all your mics are mute, and you can ask, as I said, all the questions all along the event in the chat box on the right. They will be addressed at the end of the presentation. So without using more time and further ado, I hand over the screen and the microphone to Dr. David Quek to deliver his lecture called From CAD to CCS, Translating Knowledge into New Habits. Doctor, floor is yours.
Hey, right. Thank you very much, Pierre. I think it's a pleasure to be here. And let me first of all welcome all of you. It's the evening in Kuala Lumpur, Malaysia, and I have the pleasure of trying to discuss this concept after being involved with the treatment of coronary artery disease for quite a number of years. Now, these are my conflicts of interest. Obviously, this is a speaking engagement for Servier, but I would like to say that most of the views are actually my own, but of course, Servier is not necessarily representing all the views that we are here. But nevertheless, I've taken quite a lot of care in the preparation of this presentation and to sort of give you the most accurate and complete picture that I think I can get. So let me just start by talking about the stable angina, stable CAD, stable ischemic heart disease, or is it now CCS? What's in a name and which is now preferred and why? I think in the 2019 ESC guidelines, I think it was a very bold move to move away from stable coronary artery disease towards chronic coronary syndromes. In the beginning, I was a little bit having a bit of misgivings, but when I thought and looked at it again, I think it's a very good advance in terms of our knowledge. What's new and what's good is that, of course, we recognize angina symptoms as actually being a very inexact mixed bag. It's been there for a long time. We've been treating it since, all the people have been describing about this from the time of Herberden right on to, Herrick and what have you, that, there's chest pain and it's a classic, associated with myocardial ischemia. And we talk about it as being associated with stable ischemic heart disease or CAD. But we now recognize that there's a wider clinical spectrum, from the very long-term historical events and the very varied sort of trajectories for each and every one of our patients. It's not all the same. And of course, some of them are actually due to atherosclerotic cardiovascular disease, but some of them are from non-obstructive causes. Now, one of the things about the ESC guidelines in 2019 is that it described this bit of conceptual shifts. For example, we now know that
Dr. David, I think you need to unmute yourself.
Apologies for that. Oh, shall I start
yes.
again? Oh, I think
You are back, doctor. You are back.
Okay,
It's
I'm back now.
working. Sorry.
Okay, just sorry about that. I was muted by mostly by the chairman, I suppose. Now, just to come back to these conceptual shifts, is that we now know that the presentation can be symptomatic, but they're not fixed points of disease that can fluctuate, overlap over time, and actually it depends a lot on patient characteristics and comorbidities. And of course, they can be modified and they can fluctuate with lifestyle, pharmacological treatment, interventional treatment. But at the same time, we also recognize that it can actually progress with or without angina symptoms, with or without revascularization. And the persistence and occurrence of angina, we now recognize actually is associated with higher CV risk. Now, atherosclerotic CVD is dynamic, can be stable, all right, and it's rarely related to regression. But we do know that patients can have silent sort of phases where for a long time, and then they erupt as ACS or sudden cardiac death. Now, when we talk about chronic coronary syndromes now, of course, all of us as cardiologists know about atherosclerotic cardiovascular disease. We know about the stable angina, unstable angina, non-STEMI, the STEMI. This episodic major adverse cardiovascular outcomes, and of course, it can cause death. We recognize this, but increasingly, we also recognize that there's a non-obstructive component to the myocardial ischemia, which are now talked about as non-obstructive CAD or ischemia with no obstructive coronary artery disease. And this can be represented by microvascular disease, mixed disease, including vasospasm. And because of that, this term now can be related to sudden cardiac death as well. We know that it is intermixed. You can have a blend of both obstructive as well as non-obstructive. And you may also have a chronic long-term subclinical symptom-free disease, the prognosis of which is still quite unknown at this point in time. But we recognize that when you have symptoms, then you have a worse prognosis. Now, having said that, why I prefer the term now, CCS, for example, is that because it is a spectrum, we recognize an acute coronary syndrome, your unstable angina, the non-STEMI and STEMI. It's obviously a much more acute presentation, a much more serious presentation that we need to save lives. But at the same time, we recognize that there's a component which is a spread of trajectory from the very stable phase to the silent phase to the very acute symptomatic phases. All right, and it can go either ways. All right, and of course, the unstable phases, you have much higher chances of having sudden cardiac death, heart attacks, gross cardiac damage, and heart failure. But that's not to say that in stable angina or CCS, the stable phase of it, you still can have a higher chance of getting heart attacks, cardiac damage, and it can also be debilitating with a decreased quality of life, as well as increased risk for MACE. I'll try and take you through that. So I think that the concept of having acute coronary syndrome and CCS as entities that are separate is an artificial construct. It is better known as a spectrum. So it is multifaceted. I was trying to show you what it means by that. Okay, when you look at this, this is a nice graph which I'm using now to explain to my patients how we look at the different types of patients that we have. You can have low ACS, ASCVD risk, intermediate risk, as well as high risk, in which case it all depends on the patient characteristic. Okay, in the higher risk group, of course, because most of them are from unknown or uncontrolled risk factors, they have suboptimal lifestyle modifications, and they are by and large having a larger myocardial ischemia. Those in the lower risk are usually those who have been controlled well for risk factors, lifestyle, they've got adequate therapy, and because of that, they have a lesser chance for example, for revascularization, or if they have an appropriate one. But across the board, we know that they have angina and chest pain syndrome, which can come either from any of this low risk to high risk spectrum. And the question is whether we can improve the trajectory and symptoms of angina and MACE and death. Now, I just take you through one of my real life patients who has been with me for more than 20 years. Now, this Mr. K has been seen first by me about 55 years old. And he was a smoker. He had a higher risk, his high blood tension, He's got high LDL. He's got a family history of ischemic heart disease. The father had a heart attack at about 52 and had a bypass done. But he didn't think too much about it. He carried on. So at about 55, he first presented to me with chest pains. At first a bit atypical and then a bit more angina. And we did a stress test for him and it was actually positive. But he said, look, can I just try optimal medical therapy? So we gave him some aspirins, a beta blocker, ACE blocker, and some statins. And he took it for a while. And about 9-10 months later, unfortunately, he had a non-STEMI. And then when he agreed for an angioplasty, we saw he needed 3 stents. So he was well since November 2002. And you'll notice that he did well. But about 18 months after treatment, as is wont in a lot of patients, he decided to discontinue his treatment and only took a few basic medication. I think he was taking his aspirin, but he cut down his statin and he was off the ACE inhibitor or the beta blocker. So, but he still had a long interval of untreated subclinical angina-free disease for almost, I think, 13, 14 years. Then he presented again in 2016. And this time he had some chest pains again. And we did some touch-up stents for him. And I'll show you the results in a little while. And it went well again for a while. And then about 4 years later, he started having recurrent angina chest pain. So what next at 76 years old? I'll just show you his case first. This is how he presented to me in 2016 when we saw him just about 15 years after the first index angioplasty. And you can see that he's got this T wave inversion, which looks a bit angry. He's got chest pain even at rest, but it was troponin T negative. So we did a CT angiogram, which was an urgent basis. And we saw that the stents were still available, but this doesn't tell you very much. But here is where we can see, for example, that he still has got a lot of new disease now. You can see that in the proximal LAD over the stented area, he's getting a lot of new plaques. And of course, we went in, we touched up with some scoring balloon, as well as some angioplasty, and he did actually quite well, all right? So he did well for the next 4 to 5 years until November when he actually presented. This time, it's some chest tightness on walking uphill, all right? And this is what we saw, and the bit of a T-wave inversion there. So we said, look, instead of just doing too many things for you, let's optimize your treatment. And of course, you know that his cholesterol is still very high. You can see that here. Still not well controlled. He is not the most compliant patient. He's got a bit of a glucose impaired, glucose tolerance now. And because of that, we did a bit of echo and he showed that he's got a bit of diastolic dysfunction. So we treated him better, and lo and behold, about 3 months later, he was angina-free. So it does work just treating the patients well. So what are the goals of managing CCS? I think we, of course, want to improve their CVOT prognosis. We want to have quantity as well as quality of life. We want them to be angina-free. Now, as long ago as in 1999, I think the American Heart mentioned that we should think about eliminating angina. And the treatment goals are quite simple. We want to prevent myocardial infarction and death. It's called disease modification. It improves the quantity of life. But we also need to reduce or eliminate ischemia and relieve angina and improve the quality of life. Now, in order to do that, we essentially to control all the risk factors and comorbidities, the so-called disease modification. Then you must reduce the LDL, the hypertension, diabetes. You must quit smoking, get a good physical activity going, and control the blood body weight. And of course, in managing ischemia, we just need to understand that maybe he has microvascular disease as well. So we need to treat the symptoms to resolve it, and you try and improve his prognosis. So the elimination of angina chest pain is actually becoming more important. Now, we have data now, actually very interesting from Clarify, which I participated in, that suggests that when you have ongoing angina or recurrent angina, you have a worse outcome for MACE. Let me just show you the evidence that we have. And that's one of the reasons why we treat angina. It's not benign as it is on its own. Okay, now you look back at some of the older studies from about 20 odd years ago, you'll find that stable angina is not entirely benign. Okay, it has an annual mortality sort of rates of about 1.2 to 3%, which is actually relatively high. And an annual incidence of cardiac death is about half of that, 0.6 to about 1.5%. And those with fatal or non-fatal myocardial infarction is again in the RETA2 is 0.6%, and in courage, in fact, it was 2.7%. This estimate is actually consistent with the new recent observational sort of registry. And when you have more symptoms like daily angina, you always do a little bit worse. For example, you have a higher hospitalization rate by 2 to 3 times. And of course, it increases a lot of hospital cost by almost 5 times versus those with no angina frequency. So the Clarify study that I talked about earlier is a big study. It's a registry of over 32,000 patients. And what is interesting is that we note that about 1 in 3 actually have symptoms, but there's about 67% with no recurrent angina, right? About 1/3 of them will either have angina and angina with ischemia or both. All right, now what is important is this. If you look at the outcomes in these groups, if you look at the CV-related death, non-myocardial infarction, non-fatal myocardial infarction or stroke, CV-related death and myocardial infarct, you'll notice that those with angina or both tend to have worse outcome by about 1.5 to 2 times, whereas those with just silent ischemia actually have a baseline which is equal to 1. So in other words, having angina symptoms predicts poorer outcomes and actually has a higher risk for major adverse cardiovascular events. And this in 2021, a further elaboration of the cohort that we looked at in more detail, again showed the same database, right, and the same results. If you have angina and persistence, okay, when in this group of patients, which are about 20% up here, if you continue to have persistent angina, you tend to do worse. Or if in the new group of patients without angina, you get a new occurrence in about 3.7%, you also do worse in terms of outcomes. All right, for both CV death, myocardial infarction, all-cause death, and especially the need for elective revascularization. But if, for example, you can resolve your angina or your angina is absent, you do actually very well. So in other words, what we're saying is that, about 84% of patients with angina can actually spontaneously resolve with just a medication with no intervention. But when you can resolve the angina or you can eliminate it, the MACE and the PCI rates are also reduced. So I think it's important to look at this. And I think what is new in Clarify is that it tells you that about 1 in 4 patients with stable CAD can actually resolve with conservative management on its own, right? And in well-treated group, the angina resolves without too much of revascularization as well. And the resolution of angina within the first year actually helps to predict a similar outcome with those with no angina. So the persistence or recurrence or occurrence of angina is associated with poorer cardiovascular outcomes. And the implication of this is actually quite clear, that in stable CAD, angina, anti-anginal medications and revascularization are actually beneficial, but it's mainly for symptom improvement, but not for mortality outcomes. Now, the Clarify further reaffirms that a conservative management is an active strategy for most stable angina patients. And in fact, the low rate of CV events for very stable patients who are well treated actually warrants a watchful waiting strategy before you decide that the patient has failed with medical therapy. Right? In other words, we actually show that we need to have a longer run-in period for anti-anginal drugs to work. And 1 in 3 patients at baseline will still continue to have angina patients 5 years later, reflecting that there's still an unmet need for more effective anti-anginal therapy. So when you look at this chart again, we are talking about this group of patients with the highest CAS-CVD group in that last group that I mentioned. So what are our goals for treating angina and for symptom relief? Now, remember that recurrent angina takes place in about 1 in 4 in a lot of these studies. Okay, this is a 2016 meta-analysis, which looked at the newer studies here, and you'll find that about 1 in 4 actually have recurrent angina, persistent angina. And this is one of the points that we have a residual treatment gap, that angina symptoms will persist and some of them will recur. And it's important when they recur or they persist, they have a worse prognosis. And that's one of the treatment why medical therapy is always going to be necessary and has to be optimized. Now, the question, of course, for most younger and newer cardiologists is whether PCI is always the answer. Okay, for a lot of young cardiologists, every atheroma is like a nail that needs to be hammered in with the PCI. But having said that, when you look at the chronic CCS, the treatment objectives are very similar, okay? Both for aims of treatment, it's going to reduce angina, reduce the exercise-induced ischemia, going to prevent cardiovascular events and prevent death. And of course, the optimal treatment must be when you can actually control these events, as well as to ensure patient adherence. And this is very important. If the patients don't take the medication, they're going to have recurrent events. And we need to do it with a minimal of adverse effects. Now, some thoughts to consider. I've been practicing as a cardiologist for about more than 35 years. And my contention is that I think most cardiologists are just too intervention-minded. I think they're too stent-happy. I think if you think about the strategy, I think would it be more prudent and safe to actually consider in the long term what is best for the patient? I think it's important. And that's not to say that I reject PCI. I still do PCI, but I think it has to be complementary, and we need to use each one individually or together to improve the outcomes for our patients. Now, when you look at PCI, is this the de facto treatment? My answer is probably no. Now, undoubtedly, the allure of a PCI mechanical cure for myocardial ischemia in China is highly attractive. For example, you see nice tight lesions like this. I think most cardiologists would say that you need to intervene. And when you intervene nicely, you get beautiful stents and results. It is actually very gratifying for the cardiologist and the physician. Now, having said that, this is sometimes an overkill. Okay, this is a classic case in the JACC that showed 67 stents, 28 coronary angiograms in a patient. You know, and in fact, even Eric Topol says that this is an example of a system that has lost its way. So I don't think we need to do so much of intervention. Now, let me just show you some data from a high volume hospital in New York. And this is on 51,000 patients, and 26% had symptoms. But look at the results here. 3 years down the line, about 40% had recurrent angina again. And this is from high volume status in New York City. Let's come back to Asia. And you know, the Taiwanese government has got a very nice national system where they actually looked at every case and registered every case. And if you look at it, even in the patients with a stable angina, but severe angina that needed elective PCI in senior citizens above 60 years old, they found that about 42% had post-PCI angina within the first year. So it's not something that is going to go away. So not all PCIs, unfortunately, are the same. And I think the last few years, as we are talking about more and more complete revascularization, and in fact, the complete revascularization implies a near normalization of coronary flow for better MACE outcomes. So, for example, if you look at a disease like this, which you find a CT angio, and then you do an angiogram, and then you go ahead and do the angioplasty, is this enough, or do we need to do IFFR or IFR, or even IVUS or OCT? Or do you need to do pre and post revascularization just to check to see whether the ischemia is not near normalized or not? And there are actually results for that. And this is from Rick Stone's cardiac care facility, where they did this defined PCI for 500 enrolled patients. And what is interesting is here is that it's not all the same. Now, the adequacy and completeness of the physiological revascularization is very important. So what they did was they actually measured the IFR. This is an instant wave fractional reserve. And what they did was that they found that those that actually near normalized, where the IFR is actually more than 0.95, the abnormal rate is 0.89, just to let you know. And those who just got above that but still below 0.95, there is a difference. Okay, in other words, those with a very suboptimal, which is less than 0.95, but obviously more than 0.889, they still have about 3 times more risk than those who have a better, more physiologically correct and adequate revascularization, where you have actually less chance for cardiac death, MI, or repeat PCI. Now, this is actually shown in the very recent paper just out in September this year in the FAME3 data, which shows that when you do near normalization of coronary flow post-PCI, the outcomes actually are better and prognosticate future results. Okay, so I think using IFR or FFR or even a QFR can help us to gauge completeness of the procedure and success. Now, what about invasive approaches to prevent MACE? Is it capable of detecting every culprit of vulnerable lesions or revascularizable sort of atherosclerotic plaque? And this is from the same paper that defined PCI. And I just want to show you that there is about 24% residual ischemia even in this group of patients, okay? And here, they found that about 61% had suboptimal post-PCI. In other words, IFR is still less than 0.95, and only about 40% had about near normal sort of PCI results, which is very good. Now, what is interesting is this. In spite of having this residual ischemia at 24%, it cannot actually predict which focal lesions actually is going to end up with a target lesion for the next PCI. In fact, 80% have an apparent focal lesion. So how can you tell which lesion is which? So I give you an example here. This is from a German paper where this man is a 64-year-old man, presented with anterior STEMI and had a successful PCI over that area here. You can see that here, all right? But what is interesting is that a few weeks later, 12 weeks later, he had actually new episodes of chest pains and acute coronary syndrome. So which anatomical site do you think is the result of the new culprit lesion? Is it the first diagonal A? Is it in B, where you see that irregularities in the proximal LAD? Is it in the circumflex with that little notch there? Is it in the right coronary artery with a small sort of a subcritical disease, or is it in the PD in the proximal notch in the LCA? So all of this, you need to ask yourself, but the answer is less clear than you think. It's actually at the circumflex, which looks nearly normal for most patients. So in other words, if in stable CAD, you can't lower the rate of infarction because there's the diffuse low-grade atheromas and are not necessarily indications for PCI, nor can they predictably sort of identify future sites for MACE or ACS. So incidental minor disease cannot help you to predict acute coronary syndromes. So what should be the optimal care? I think we need to think about using more OMT aggressively with PCI. Okay, which to choose, I think is very important, right? We need to consider the comorbidities and the patient characteristics. And I think you need to personalize it. When you look at it, you're very high-risk patients. You need to be very aggressive in the medical therapy, timely backup revascularization strategies. You need to be more holistic, multi-risk factor optimization. We need to actually look at maybe the microvascular and vasospastic conditions as well. And of course, you need to talk to the patient about adherence issues. And the decision to choose either PCI, CABG, or OMT should not be based purely on anatomical factors. You need to look at all the risks. Now, just to tell you that recent studies suggest that 50% of all stable CCS patients still had PCI as an indication, okay? And if you think about it, not all obstructive disease actually present with acute coronary syndrome. Here's a paper from Musley. It showed that anything from 4 to 14% of men had no obstructive disease, even though they presented acutely. And there's from 9 to 30% of women, there's no obstructive coronary artery disease. Now, the coverage study, I think we all know from 2007, showed that there's no difference whether you use PCI or OMT. And this was reaffirmed in the extended coverage in 2015, that there's actually no difference in the outcome after 12 years if you follow them up with stable IHD. And the ischemia, the 5,000 over patient study, again showed in the most recent paper that there's no difference in outcome between the invasive and the conservative arm. There's no survival benefits between the PCI versus OMT, but there's some contention about it. In fact, there's a meta-analysis in 2020 after the ischemia data, which shows that there's actually no difference in terms of mortality for stable CAD patients. It is slightly better for acute coronary syndromes and unstable CADs. So when we think about CCS and think about PCI, we recognize now that OMT is not inferior to PCI for stable disease, right? And we are not doing enough, I think, that to truly optimize our patient and think about guideline-directed medical therapies. And I think for a lot of cardiologists who have no time, or they say they have no time, we are under-informing or guilty of under-informing the patients. And we are so hardwired into technical revascularization, the PCI. We cannot accept that medicines are real therapies. And perhaps I think we've become too cognitively biased into making more skewed decisions. And it partly is because I think a lot of cardiologists, especially younger ones, are learning all the skills quite early, and they become quite skillful, all right? Unfortunately, what they have forgotten is that what is really beneficial for the patients in the long term. So I think as a senior doctor, I think for most of us, we need to be aware that not all of this angina is due to obstructive CAD, and we must be more aware of those with no obstructive disease or microvascular disease. Now, having said that, if you don't have any obstructive coronary artery disease, it does not mean that the risk is actually lower. You are still associated with increased risk. This is a paper from Jesperson, and this is an interesting paper looking at a group of patients for men and for women that they are symptomatic and looking at whether they've got single, normal, or triple vessel disease. And if you just look at those with normal in the brown bar, coronary arteries, and yet they have angina symptoms, they do worse than those who have no symptoms. Okay, in fact, it is quite close to those with even single or double vessel disease. So in other words, symptoms of angina are important and we need to treat them better. All right. And remember that patients still die about 0.6 to 3%. So the microcirculation has now been studied quite a lot in the last, I think, 15 years or so. And I think one of the things that has come true is that when we're talking about PCI, we are dealing essentially with the epicardial vessel, which is about more than 500 micron in diameter. But we've forgotten that there's these pre-arterioles, arterioles, and capillaries, which are much smaller, which may contribute also to ischemic syndromes. And in fact, what is clear is that we actually done some measurement on this. And even mild stenosis, of course, most patients can tolerate this. You find that the hyperemic response, for example, during exercise or exertion, can still be very good. You can actually get a normal sort of a response and get enough blood flow to the myocardial cells. In diffuse atherosclerosis, there's some lowered, but still adequate. And sometimes patients may not actually present with symptoms. But in severe stenosis, you will note immediately that there is actually a decrease in how you respond to exercise or in increased effort. And it's also true for those with microvascular disease. In other words, they cannot have this increase in hyperemic flow. And it's one of the reasons why we now must look into not just the structural abnormalities, the focal coronary artery disease, the bridging, the diffuse atheroma, the microvascular constriction. We need to look beyond that. Of course, in LVH, we also have sometimes some angina as well. So we need to think about the functional aspect and see, and I suspect that in the coming few years, we'll be doing more and more structured acetylcholine provocation tests, especially the graded ones to determine for microvascular dysfunction as well as endothelial function. And I think this will be the way for the future to look at the microcirculation. So beyond this, it's going to be important. How do we reappraise this? Now, of course, we have been talking about focal and diffuse CAD. Let's not forget about the others, okay? I think the important thing that has come to the fore is that we need to establish that there is actually an ischemic myocardium at risk of more than 10%, all right? Has been shown by Modric a few times now. And I think we need to look at more physiological flow. So in other words, IFR, FFR, or QFR needs to be done for PCI patients. And remember that we are not just talking about obstructive, we need to talk about the smaller vessel disease. Now, this is a paper taken done by Taketi. And it's interesting to note that in this cohort of patients, where they looked at patients with angina plus minus ischemia, they found that about 43 to 46% actually had no obstructive pulmonary artery disease. And out of this group, about 70, 80% of them had coronary vasomotor dysfunction. And out of this group, about half of them actually have both, including vasomotor disease and microvascular disease. So in other words, you're going to have more and more of this non-obstructive CAD to contend with. So does it matter if you have microvascular disease or impaired coronary flow reserve? Well, it does matter. Okay, for example, if you have both severe microvascular disease with obstructive disease, you have the worst outcome, the red bar here in B. But even if you have moderate CMD and non-obstructive CAD, you still get worse outcomes in terms of that. Is that been shown out? Yes. So when you measure the microvascular reserve, for example, in the coronary flow reserve, you'll note that those with CFR of less than 2, in other words, where it's impaired, they tend to do worse. And you have actually more than 25% increased chances of MACE. And if you also have diastolic dysfunction as tested by echo or the EE prime, for example, you have higher rate for hospitalization. So in other words, having microvascular disease also has got worse prognostic outcomes. Now, let's talk about patient-centered approach, okay, the pharmacotherapy. Now, we already know that there's really no universal definition of what's optimal, but we need to look at multiple mechanisms more closely. Okay? We need to look at the hemodynamic profiles, the comorbidities, the impact on their symptoms and survival. I need to choose the best scenarios. In other words, you need to individualize the characteristics and the features of the patient, and then choose the anti-ischemic drugs appropriately in a patient-centered, very personalized manner. Okay, and in fact, this is what has been proposed, Bowden in the Lancet, which suggests that we really need to look at the various types of causes of ischemia and treat appropriately. And he actually recognized that about a third of angina patients are not receiving adequate OMT before revascularization. And optimization should at least last 3 to 6 months and not just 1 or 2 weeks that a lot of people do. Okay, and of course, the symptomatic treatment should be targeted at the mechanistic causes if you can. And of course, they mentioned that trometazidine, ivermectin, for example, may become first line in most of the patients with non-obstructive coronary artery disease, particularly those with microvascular dysfunction. Now, when you look at these mechanistic targets for anti-ischemic drugs, this is a very busy slide, but just to show you that we need to consider beyond just looking at this, but looking at metabolic sort of abnormalities where trometazidine, renalazine may be useful, and also in those that can be newer, like ivermectin, looking at that. And PCI is just one of them that helps in cases where there's a definite decrease in oxygen supply or blood supply. So if you look at this summary that I've collated, all of this anti-anginal therapy actually help in terms of improving symptoms, but none of them actually will impact on mortality. All right, and this is the same for PCI, as it's shown by the COURAGE, the FAME2, the BERRY, the ORBITA, and the ischemia trials. So we can actually use and combine earlier any of the medications to enhance the optimum sort of a medical therapy for most of our patients. So should we think about still the stepwise sequential approach, or should we go into a multi-drug patient-centered approach? I think this thing about first line and second line is probably archaic and is no longer the preferred one. Should these traditional hemodynamic drugs be always the first choice? I mean, there are some arguments for and against this, but nevertheless, I think it's important to look at the patient more holistically. All right. In 2016, I think Manolis and John Kemp came up with this nice chart looking at hemodynamics based on heart rate and blood pressure. And again, here they were talking about first, second, and third line. But now in 2021, they've revised this and said that, look, forget about that first or second line. Think about what fits the patient and what is appropriate for the patient. For example, you can use any one of these interchangeably or in combination and practice a more personalized, patient-tailored approach to these features. And this is in a way being followed by the ESC 2019 guidelines, which came up with these 6 scenarios here of standard therapy, high heart rate, those with low heart rate, those with healthy dysfunctional heart failure, those with low blood pressure. But nevertheless, they still go on that first, second, and third step approach, you know, and again, is this really necessary? I mean, I put a question mark to this, and a few of us now consider that maybe this is not the way forward. And in fact, this is from Professor Rosano, which actually pointed out that in that 6 scenarios, they've forgotten about a lot of other cases where the patient had obstructive pulmonary disease, peripheral vascular disease, diabetes, venous insufficiency, those with worsening heart failure, for example, those who have been revascularized with heart failure or LV dysfunction, those with microvascular disease, those with no obstructive heart disease. And what about those with infarction, which is also the MINOCAS, and those with high heart rate and low blood pressure? So there are lots of categories that are being missed out in just this category. So we need to have these clinical phenotypes, which I think will be much better. Now, the good thing about the ESC guidelines here is that they've come up with these anti-ischemic agents and they've quantified it, all right? And most of them actually either 2A for second line and first line for some cases for example, for trometazidine, ivermectin, renalazine, and those with low heart rate, low blood pressure, select patients. And in fact, they've actually recommended that for medical therapy, usually requires more than 1 drug for angina relief. Right? I think this is very important. The level of evidence is actually a C based on consensus, but the class is 1. All right, and in fact, the add-on anti-ischemic treatment actually has been shown to be beneficial and should be considered in patients in the either beta blocker or calcium channel blocker. Now, the ORBITA study is actually an interesting study. All of us recognize this, that it just showed that the sham PCI did as well as the PCI. But actually, the background to this is that the ORBITA study is an aggressive strategy of very early anti-anginal medication initiation, combination, and up titration. In other words, they try and push as much as possible the drug dosing, as well as the multiplicity of drugs. In fact, most of them ended up with more than 3 anti-anginal drugs. even with a PCI. And that's one of the reasons why the patients have a resolved angina. About 50% of them actually resolve with 3 or more doses. So aggressive and up titration of medications and combination is crucial and important to achieving parity for PCI and angina relief and benefit. Now, what about the role of trimetazidine? Okay, here, I think we know that trimetazidine is actually a metabolic modulator, and it possesses multiple potential anti-ischemic mechanisms that can cause myocardial ischemia. Right now, the mechanisms are actually very complex, but nevertheless, this is sort of a thing, the proven pathways that seems to be cytoprotective. Okay, in other words, it reduces the FFA oxidative metabolic pathway. It decreases the oxygen demand for ATP production. Of course, it reduces the cellular overload for lactate and hydrogen ion or acidity, sodium and calcium. And also, it prevents cardiomyocyte stiffness. There's also some free radical effects, and in terms of apoptosis as well. In other words, it improves the anaerobic metabolism for patients, and that's why the patients actually have improvement in myocardial ischemia symptoms and angina. And this is actually not new. In more than 20 years ago, when it was compared with metoprolol or added on to metoprolol, they found that trimetazidine works very well. It improves the time, all the exercise parameters here, right? And decreases the angina attacks, decreases the nitrate use, decreases the angina pain intensity. So it's actually better than using metoprolol alone. So combination with trimetazidine with your first-line drug actually works very well. This is the major study, the TRIUMPH study, which actually showed that it also improves the quality of life. Okay, about 68% reduction in the mean number of angina attacks per week. And this is only a short study of over 8 weeks. Now, having said that, there have been a few meta-analyses now. And in summary, okay, the exercise tolerance parameters are actually improved by about almost 3/4 of a minute, which is a substantial amount of time to push a patient. And the total exercise duration is improved by almost 1 minute, and the ST depression, the time to angina, again, almost 1 minute. So again, this shows that trimetazidine works. Now, across the board, it is shown that it is equivalent as an anti-anginal for exercise tolerance and symptom relief. And this is a big meta-analysis of over 19,000 patients. And when you look at it, it's equivalence in improving exercise tolerance. There's no difference between one from the other. At the same time, in terms of improving symptoms, it's actually better in controlling angina control in terms of clinical sort of criteria as well. So it actually works very well. It can be used as first line versus beta blocker, calcium channel blocker. It's actually superior to long-acting nitrates. It's fast anti-anginal effect within 2 weeks of initiation, and also is effective in microvascular disease. It's very effective in diabetes, heart failure, excellent tolerability, no effect on hemodynamics, and there's no metabolic disturbance. I'll just show you some of the benefits that we can actually show in terms of LV ejection fraction, which is very interesting here. This is taken from just looking at angiography and echocardiography and meta-analysis. And it shows that there's actually an improvement in LV ejection fraction, decrease in LV wall motion score index, and decrease also in LV and systolic volume. Okay, another analysis, this time looking at a bit more detail, also showed the benefits accordingly. And this is in the patients with diabetes. And again, tells you that the parameters are also better. So I think for patients with diabetes, this is one of the important therapeutic armamentarium that you can add to the patients. All right, another case in those with cardiomyopathy or ischemic cardiomyopathy, again shows you that in LV ejection fraction is improved, the systolic volume and systolic volume and diastolic volume is also decreased, and the ejection fraction is actually markedly improved. So again, telling you that it's beneficial. And in fact, in the ESC 2021 guidelines for heart failure, you'll note that trimetazidine has now been class 2 for patients, all right, and also ivabradine. So if you look at this, you will find that trimetazidine has got a way to go. Now, this is from the real-world data, the ODA data, which is from Russia, stable angina with persistent symptoms despite therapy. And this is a very interesting study because it shows you that if you use trimetazidine over a period of time, you can actually reduce the angina attacks as well as the nitrates. All right, and you improve the CCS class 1 tremendously. And also very important is that the patient adherence is very good, okay, for most of these patients, especially for those who are on this medicine to reduce the angina. Trimetazidine 80 milligram, the long-acting one, is actually very effective. And this is shown even in those with new angina attacks within 1 year, or those beyond 10 years, where you have benefits still in terms of getting angina relief. So what is the treatment that we should actually give to our patients? Don't forget the disease-modifying process that we need to do, okay? Antithrombotics, aspirin, and clopidogrel, where there's unstable feature, is still necessary. And in that case, you need to think about gastric protection. You need to reduce LDL. I can't emphasize more than that. It's a class 1 indication. You need to think about RAS blocker for blood pressure, heart failure, diabetes. Beta blockers is 1 to 2A. And of course, now you need to think about all the anti-ischemic agents. Short-acting nitrates is one of them, but trimetazidine is certainly another one to consider, class 1 to class 2A and 2B. And we need to individualize the treatment, okay? Now, could we still go by first and second line? My answer should be, I think, no. We should move beyond this, all right? And this is taken from the paper from Roberto Ferrari, and they've actually advise and recommend that we should move towards a bit more of a concerted effort in terms of looking at patient characteristic and profile. And we can use most of the drug interchangeably or in addition, except for those in the red line where you shouldn't be using verapamil, a calcium channel blocker with ivabradine and beta blockers. But the rest of you can actually combine nicely. So they've come up with this diamond approach, looking at patient features as well as comorbidities here, and using what we call the traffic light system, looking at red meaning you is contraindicated, but those dark green meaning that you can actually use it as the first line, those lighter green is recommended, and those with white as can be used in addition. So this diamond approach actually is a very personalized way, because when you look at it, I'm not sure whether you can read it, is that we can look at various profiles: high heart rate, atrial fibrillation, heart failure, left ventricular dysfunction, hypertension, bradycardia in the patient features, and then they look at the comorbidities, whether they got diabetes, microvascular angina, coronary artery spasm, AV conduction problem, peripheral arterial disease, obstructive lung disease, and chronic kidney disease as well. So all of this actually tells you need to personalize the treatment, okay, manage them better. And I think that trimetazidine and ivabradine actually figure prominently in most of this, in this traffic light sort of approach to comprehensive treatment for CCS. And in fact, in 2021, I think I've shown you this paper before, they've recommended looking at various components of a patient characteristic. For example, those with significant AV conduction, those with microvascular angina or atrial fibrillation, and see which drugs are actually preferred and can be used together or in combination, again, for heart failure, for chronic obstructive airway disease, and in diabetes. And those in yellow are actually preferred, and white is possible. So in other words, we are tending towards this. This is another paper just out in 2021 in Asia Reviews in Cardiology, where they actually asked to use a compass, a pathophysiological compass in treating our patients. So here, this is the next one. It shows you that the heart rate probably needs to be figured, the blood pressure needs to be configured as well. And you'll also look at the ejection fraction as well, and see whether each one of them can be used. For example, trimetazidine can be used in a few of these conditions, as well as in ivabradine. So in other words, there's a convergence of consensus that we should move towards a more targeted therapy in medical practice. All right. And so we want to translate this. How do you make it better? Now, remember this Mr. K that I showed you before, the recurrent angina. Now, I just want to show you that he's got these few features here, right? He's got high heart rate, he's got hypertension, he's got left ventricular dysfunction, got diabetes, got a bit of microvascular disease, he's got chronic kidney disease now. So we need to optimize all his treatment. You'll find that his LDL is still not optimum. He's got a bit of a glucose impair. And so we treated him a bit more aggressively. I've moved him into getting a ivabradine because he complains of fatigue with bisoprolol. I've increased the statin to add ezetimibe. And then we added a trimetazidine 25 BID and later switched to the 80 once a day. And actually, he did very well. All right, he became much better. I'll just show you his SAQ score. This is his ECG in 2020. It's much improved now. So when you look at his score, he started with about 50 in June 2020. And now he's gone up to about 82. And latest in June, when I saw him, he was actually feeling very comfortable. I'll just show you another case here. A patient who actually did not undergo any angioplasty. He's got a patient with angina, very classical, on treadmill, at 58 years old. This is a stress test result, but you can say she's a woman. So we did a CT angio, which actually showed some calcifications in the mid-LAD. But when we interrogate the narrowing, it wasn't very severe. So we thought it might be to be small vessel disease. So we treated her medically. And this is in March 2022, and it's about 12 years on, and she's actually been very well. Again, on this treatment to lower the blood pressure, a bit of a beta blocker, a baby aspirin, controlling the cholesterol well, as well as adding trimetazidine. And you can look at these her scores, SAQ score, the Seattle angina score, started with a very bad, about 38.9, and now is about 87, 88. It's almost normal for her. And she's very happy. She's been coming back for regular follow-ups. So in other words, this is one of those, of course, in the lowest strategy of patients where the trajectory is rather stable. All right. So nevertheless, patients can be treated without angioplasty. So my suggestions on how to improve clinical practice would be this. We need to think about OMT on an individualized combination therapy. I can look at the comorbidities, the risk profile. Of course, we need to think about the anatomy as well, and functional ischemic patterns. The greater use of anti-anginals can safely and cost-effectively treat CCS, quite well, and with equivalent outcomes, good quality of life, and safe. All right. And there's also a component of non-obstructive CAD to contend with, and this is where, for example, trimetazidine can be very useful. But unfortunately, for now, we don't have outcomes in terms of MACE. Okay, so we should complement each other from both PCI. PCI need not be the default sort of modus operandi for most CCS. Okay, we need to be a bit more focused on goal target OMT. And medication-based OMT does not put our patients at risk. I think that's the more important thing. Of course, we need to revise here and there. I just want to emphasize again the goal-directed ones, that you need to use antithrombotic, cardioprotective drugs, heart rate lowering, lower the LDL. But at the same time, we need to think about anti-anginals to improve quality of life, right? And always review. I think that's an important one that I want to emphasize. So having said that, I think the drugs with the neutral effect, for example, on heart rate, should be considered more. And I think we need to look at the patient and give the patients a more complete sort of a treatment for our treatment of chronic coronary syndromes. So with that, I'd like to thank you, and greetings from Kuala Lumpur. Okay, thank you very much for listening to me.
Thanks, Doctor, for the presentation. So for all the audience, it's now time for a Q&A session. So if you want, you can directly type your question in the chat, and Dr. David Kwek will
I'll try to address those questions.
So you can even open your mic if you prefer. Feel free. So I see people coming and leaving with the camera.
Yeah.
So
the good thing about webinar is that we can be wearing whatever we want.
Yes. So maybe, Doctor, I will start by asking a question on my side, and to let people the time to type in.
Yep.
So I would like to know a bit more about the role of long-acting nitrate in your practice, and most importantly, do you prescribe it for a long period of time?
In fact, there are two reasons why I've actually practically stopped long-acting nitrates now. One of them is that if you know, most of the patients who are on long-acting, they tend to develop what we call tolerance. In fact, the patients do not get benefits after about 1 or 2 months. And of course, I still use some short-acting nitrates when they need to use it. But having been using trimetazidine for some time now. I find that it works actually very, very quickly. So usually in the beginning, I will give them either a spray or some GTN, and I will start them on Vastarel. And within usually about 2 to 3 weeks, they are already feeling much better and they don't need to use it as much. Now, one of the other problems we have in Malaysia is that we can get Viagra very readily. And, a lot of Asians are very mindful about their activities, sexual activities. So there's a lot of abuse. And I've been a bit cautious. I think we have about 2 cases now of severe hypotension in our ED because of that. So partly because of that, I've sort of been shrinking back on my use of long-acting nitrates.
Thank you very much.
That's my practice, yeah.
Crystal clear. So I will move to some question that we have on the chat. We have a recurrent question from some colleagues located in France and some of really good friends from Hong Kong as well. So they would like to know, in your clinical practice, of course, that what's the role of Vastarel after PCI? And if I can add, do you continue first Vastarel after PCI?
Well, there are some papers which suggest that when you're doing PCI, during PCI, you may actually decrease the rate of rise of troponin, for example, particularly those which are severe stenosis, and that you may actually improve. And the ischemic time actually is going to be reduced as well. But unfortunately, if you look at the bigger study, which I think what most people may remember, is that it doesn't seem to improve on the mortality aspect of it. So will I continue to use post-PCI in some of the patients where I recognize that there are possible sort of microvascular disease or small vessel disease where I cannot fully revascularize a patient, for example? I often continue to use Vastarel, and the patients do very well. I continue for about 3 months or thereabouts, and then I can stop. But for a lot of patients, if they do develop recurrence of angina, which invariably about maybe 20 up to 40% will get, then you can restart them again. And I've got lots of patients on it for actually literally years, and they are actually very comfortable. I just want to preempt this question now. I've used trimetazidine for more than 20 years. I've not seen it really related to anyone with this Parkinson type kind of conditions. I mean, most of them who have got Parkinson's disease is because of ongoing sort of hypertension that's not well controlled or what have you, but not really anything that comes to mind. So I think I'm not concerned about that. Another question which I want to preempt is that although we say that you have to be cautious in chronic kidney disease, I've used it down to a level of about 20-25 for eGFR, and I think there's no build-up effects, and the patients are quite comfortable with it. In fact, I have one patient right now who was in because of kidney failure. And he says, look, I'm still going to continue. I think maybe one day I'll share the case. He's got a left main stem that I did about 8-9 years ago, and it's still surviving very nicely because the surgeons offered him surgery and quoted him a 10% sort of a mortality rate, and therefore he was very unhappy to do that. So we did the stenting for him in the left main. And but he still has ongoing on and off angina. He's got heart failure. He's got chronic kidney disease, class 4, and so we just continue with the treatment.
Thank you, doctor, for the question. One other question, which is a bit related, which will be double as well. So you mentioned about different type of patient. Can you be a bit more precise on the type of patient that in which I will say trimetazidine will work best?
Well, I think those whom you suspect will actually have small vessel disease, for example, where you think that the PCI may not be doing the most for the patients. Those with microvascular disease, okay, again, some of that can be under presumption. Those with vasospastic disease, those with ischemic sort of cardiomyopathy, where they've got some ischemic component to it, they tend to do very well, partly because I think if you look at the meta-analysis that I've shown you in diabetic patients as well, those with a bit of ischemic cardiomyopathy patients, where there's an ejection fraction that's marginally lower or whatever, then you can actually see some improvement in that. Also a reduction in the size of the left ventricle, and all this sort of pleiotropic effect of trimetazidine, small as they may be, may actually contribute to the patients actually feeling better. I think the question is getting rid of the angina equivalent. And if you can actually do that, then you go ahead and use whatever is there to help the patients.
Thanks very much. So I'm looking at the chat. Maybe we can have one last question. Yes, there is a really interesting question on exercise capacity. So I'm not talking about Viagra, I think, on this one, but for you and your peers in overall, how important it's the measurement of exercise capacity in the overall reduction of symptoms?
I think I still am one of those old-fashioned guys who believe that you need to test for functional sort of myocardial ischemia. All right. Now, one of the reasons is because in Malaysia, we have very few centers that actually can do PET or myocardial imaging. And one of the things that is only in few centers. So not most of them can actually check to see whether they've got ischemic components to it. So the functional stress ECG or stress echo is still a very useful way of determining ischemia. And once they've got ischemia, it's actually quite useful to actually test them. Do I test them pre and post treatment? Usually my answer in my younger days, my answer would be yes. But as you practice long enough and the patients are feeling comfortable, there actually is no need to actually do any repeat stress testing. At the most, it'd be once every couple of years or thereabouts if the patient is worried or the patient is young.
Thank you, Doctor. So, Doctor, I would like to thank you a lot for this eloquent and enlightening presentation. So I would like also to thank our audience for taking the time to join despite their busy schedule. And I hope they all enjoy this session and find it useful.
Thank you very much. Thank you very much.
I see in the chat that there is still some questions. So I will only suggest you to get in touch with your local service representative, and I'm sure they will be able to assist you, and we will communicate with them. So to conclude and to finish with, I would like to thank you all for your continued support and partnership over the years. So as company, Servier will continue, and you can be reassured on that, to remain strongly involved in the field of cardiology with a lot of new things, new researches, new single pill combination, and around the pill solution. So for the years to come. So with this, I will end this meeting. So stay all safe. Thank you a lot again, Dr. Kwek, and stay safe and well.
Hey, thank you very much, Pierre. Right.
Bye.
Bye now for now. Thank you.